This is the story of a 44-year-old lady who presented with history of tiredness, body ache and fever for a month. She described her tiredness to be a generalized feeling of unwellness, but her activities of daily living were not affected. She was a homemaker. She was able to carry out her daily activities, and she reported having fever. It was low grade, intermittent, once in 10 to 12 days, documented temperatures of 100 Fahrenheit. And this fevers used to last for 4 to 5 days, and she remained afebrile for another 10 days. So this was going on for a month. She did not report any weight loss, and her appetite was good. Past history, she had a long past history. In 2014, she was diagnosed with pulmonary tuberculosis, microbiologically proven, and she completed first-line ATT. And she was incidentally found to have colonic polyps when she was evaluated for persistent iron deficiency anemia with stool occult bloods being repeatedly positive. And because there were hundreds of colonic polyps, she underwent restorative proctocolectomy prophylactically, but subsequently the biopsy specimens did show invasive adenocarcinoma with staging of T1N0. So because it was a T1 tumor, only surgery was needed in 2015. 2 years later, she was found to have solitary hepatic metastasis, which was excised, and following that, she received 6 cycles of chemotherapy with Folfox. This regimen contains a platinum compound, 5-fluorouracil and leucovorin, and then she was on capecitabine maintenance. All the chemotherapy was finished by March 2019. She presented to us 1 month back. So about a year, she was off all chemotherapy agents. She also had indeterminate thyroid nodule, ThyRADS 3, and was on regular follow-up for the same. She had a left ovarian complex cyst, was on follow-up for the same. She had a left thigh 5 centimeter benign tumor excised and reported as myxoma. She had multiple lipomatosis. So for all this, over the years of workup, multiple underlying malignancy syndromes were considered. There was no significant family history of malignancies. Syndromes like FAP, HNPCC, Turcot's, Gardner's, all were thought about, but she didn't fit in particularly into anything in specific, and no genetic testing was done. So when she presented to us with this history of persisting tiredness, intermittent low-grade fevers, her examination findings, the vital signs were normal. She was pale. There were no palpable lymph nodes. She had multiple lipomas distributed over her body, and she did have sternal tenderness and tenderness over her bilateral clavicles. Systemic examination, there was no organomegaly, and there were normal findings. So summarizing, predominantly presenting with constitutional symptoms with bony tenderness on examination, she has underlying malignancy syndrome with adenomatosis of colon, lipomatosis, soft tissue benign tumor, ovarian cyst, thyroid nodule, and she has received platinum-based chemotherapy in the past for the colonic malignancy and past history of pulmonary tuberculosis. So broadly our thoughts were, is it a chronic infection that is going on for a month, tuberculosis, i.e. recurrence of a malignancy, or is it a new second malignancy? These were the thoughts. Investigations, she was noted to have pancytopenia. Total count was 1,700. Hemoglobin of 8.4, which it was a normocytic anemia. TSAT was 13%. Retics were on the lower side. She had moderate thrombocytopenia. Organ function tests were normal except for mildly elevated alkaline phosphatase. Her chest X-ray did not show any new infiltrates. Cross-sectional imaging, there was no evidence of malignancy or disease progression. So it's been a year after she completed her chemotherapy, and there is persistent pancytopenia with constitutional symptoms. The possibilities that we considered were, is it a marrow suppression because of a severe B12 deficiency, folate deficiency, because she's post-colectomy with a ileal pouch and she keeps passing stools frequently. Is there some malabsorption contributing to B12 deficiency? Did she have a marrow infiltrating process because there was tenderness over the sternum and the clavicles, infection like tuberculosis, recurrence of a malignancy with metastasis, or a hematologic neoplasms because she's predisposed for the same and she's received chemotherapy, or a myelodysplasia which is having an ongoing chronic pancytopenia. We did consider a de novo myelodysplasia because she is predisposed, or a therapy related because she has received chemotherapy agents in the past, or a marrow failure. Lower down was a peripheral destruction because she is a young lady. So her LDH was normal, B12 levels were normal, folate was normal, bone marrow showed hypocellularity, and there was dysmegakaryopoiesis. To confirm, we did cytogenetics that showed monosomy 7. So our diagnosis was myelodysplastic syndrome, probably therapy related, and has a cytogenetics of monosomy 7. And this is the risk categorization, MD Anderson risk scoring. So this is based on few factors, and when we calculate this, her risk would be intermediate to high risk. She is treated as high risk because I'll be coming to it later. So therapy related MDS happens following any chemotherapy or radiotherapy, usually with a latent period of 5 to 6 years. So what is done for these patients? Allogenic stem cell transplantation or hypomethylating agents. Hypomethylating agents are azacitidine and dacicitabine. These are the agents that are used. So prognosis is quite guarded. Median survival is in months, and allogenic stem cell transplantation is the only curative option for them. Why is the median survival so less? Because these patients have poor risk cytogenetics, like what we saw in this patient, monosomy 7, and that makes them resistant to chemotherapy, and they are already patients who have underlying another malignancy because of chemotherapy, radiation, and they have a baseline poor functional status. What is the difference between de novo versus therapy related MDS? They do have very poor risk cytogenetics, and which are present in about 50 to 70% of those with therapy related versus few percentage in de novo MDS. So for our patient, she is treated as high risk MDS because of two reasons. She did not have such a long latency period of at least 5 years, and she does have an underlying condition that would predispose her to further malignancies and the progression of the MDS to a myeloid leukemia soon. And she's planned for allogenic stem cell transplantation. Learning points: persistent or a new onset pancytopenia following a chemoradiation in any patient needs to be evaluated in detail, and this entity called therapy related MDS needs to be kept in mind, which happens usually following alkylating agents like cyclophosphamide, but oxaliplatin that she received is also known to cause therapy related MDS. There are not many studies available because therapy related MDS is a small number of patients who develop it, and there are retrospective studies only available. And to be kept in mind is that they have very, very poor prognosis because of the very poor cytogenetics that they have. And allogenic stem cell transplantation is curative, but how far can we go ahead in doing that? Because these patients already have organ dysfunction, they are post chemoradiotherapy, and their functional status may be poor. And in that case, we would give them hypomethylating agents which are shown to delay the progression to myeloid leukemia. And we also learnt about, there are many scoring systems, WHO scoring system, IPSS, generally available for MDS. What is said to be best for therapy related MDS is the MD Anderson scoring system, and based on that they are risk stratified. Thank you.
Thank you, Esther. Any questions?
So the constitutional symptoms itself we were not able to explain, sir. We did look for indirect markers of TB. Probably, sir, because the marrow is just one area where we sampled.